So let's talk about HOCM, which is hypertrophic cardiomyopathy. So hypertrophic cardiomyopathy is defined as left ventricular hypertrophy that occurs in the absence of causative hemodynamic factors like hypertension, aortic wall disease, or systemic infiltrative or storage disease. So hypertrophic obstructive cardiomyopathy, asymmetric septal hypertrophy, and idiopathic hypertrophic subaortic stenosis. So all these three comes under hypertrophic cardiomyopathy. So coming to the etiology of hypertrophic cardiomyopathy, usually has autosomal dominant pattern of inheritance. There is a mutation in the sarcomere genes. The mutation leads to enhanced calcium sensitivity, maximal force of contraction, and ATPase activity. It leads to abnormal energetics and impaired alterations, which will lead to the misarray and misalignment of myocytes and myofibrils. Fibrosis and microvascular disease may also be present, which will further lead to interstitial fibrosis which is always detectable even before the hypertrophy develops. It is due to the early activation of profibrotic pathways. The scar areas can be a substrate for development of various ventricular arrhythmias, which are usually found in case of hypertrophic cardiomyopathy. So there is increased thickness and decreased luminal area of the myocardial vessels. There is microvascular ischemia and angina. Macroscopically, hypertrophy manifests as a non-uniform ventricular thickening. Interventricular septum is a typical location of myocardial hypertrophy. In case of the clinical features are left ventricular outflow tract obstruction. There is systolic dysfunction due to drag forces, which pushes the anteriorly displaced mitral wall leaflet against the hypertrophied interventricular septum, which further lead to mitral leaflet coaptation, which leads to posteriorly directed mitral regurgitation. To maintain stroke volume, myocardium contracts forcefully, so there is increased pressure. So because there is increased pressure, there is higher shear wall stress, which leads to increase in the oxygen demand. The murmur in HOCM is usually ejection systolic murmur, which is harsh, which is late peaking, enhanced by standing from squatting position and Valsalva maneuver. Treatment is usually beta blockers, L-type calcium channel blockers, diuretics, surgical myomectomy. Mitral wall repair or replacement is unnecessary as eccentric MR usually resolves with myectomy alone.